So our third speaker is Ermias Diro, who's associate professor in the Department of Internal Medicine at the University of Gondar, Ethiopia. Ermias his studies have been looking at strategies to better manage Leishmania and HIV co-infection, and he's coordinator for the University of Gondar Hospital and Global Health Committee for Collaborative Drug-Resistant Tuberculosis Treatment Program as well. And so he's going to tell us today about current challenges in HIV, Leishmaniasis co-infection.
Thank you. Good afternoon. I will take you to a different disease and a different country. So I came from Ethiopia, still having some jet lags. And I work in the northwest part of the country, 750 kilometers from the capital, Addis Ababa, in a university called Gondar. It is yet a young university with only 60 years of experience, but all the catchment area has a lot of tropical diseases like Leishmaniasis that I'm going to present to you. I'm a clinician, so I see patients. So I have put some of the cases that I am getting while working in the hospital. Like this is a patient, 40-year-old male on antiretroviral therapy for 9 months. He has history of tuberculosis before and history of visceral Leishmania treatment twice. And then this time he presented with high-grade fever, and actually he was referred to us from a district hospital after they tried to settle the diagnosis, and there was no confirmed diagnosis for his persistent fever this time. And when he was referred to us, he was having this diffusely swollen palate. So commonly when we get this kind of lesions, we entertain possibility of lymphoma or okay, thank you. We think of either oral lymphoma in HIV patients or Kaposi sarcoma kind of lesions, but this ended up to be Kala-Azar or visceral Leishmania. Another case, this is also another common type of case that I see in the hospital. 30-year-old male patient with HIV and visceral Leishmania co-infection. This patient was on antiretroviral therapy and cotrimoxazole preventive therapy. He was having history of Leishmania even 4 years ago, and he came with quite very low CD4 count with big spleen, and aspiration from the spleen showed a parasite load of +4. It is just a logarithmic expression of the load of parasite that we get on microscopy. And then he was treated with an antimonial drug. Glucantin is one of the antimonial drugs. The normal regimen is 30 doses with daily injection for a month. And despite that standard treatment, the patient persistently was having parasite in his tissue aspirate. So prolonged treatment was given with liposomal amphotericin B, ambizome. And after 6 doses, which is about 30 milligram per kg total dose, his CD4 count was slightly elevated. Otherwise, there was no much clinical difference, but at least the parasite was cleared this time. And then we appointed him to come after 6 months. After 6 months, he was having a high load of parasite again, though the patient was not that much symptomatic. So these are the kind of cases that we diagnose in our Leishmania treatment and research center. And over here you see a microscopy slide of full of Leishmania parasites that we detected. So to say some introductory things about visceral Leishmania, or which is also called Kala-Azar. It is a vector-borne protozoal disease. It is transmitted by sandfly, and it's intracellular organism affecting macrophages, and predominantly the reticuloendothelial tissue are affected. Patients presenting with huge hepatosplenomegaly, and typically patients in Sudan present also with lymphadenopathy. It causes persistent fever and as a result severe malnutrition, cachexia. So it is found in quite several countries, around 70 countries have visceral leishmania, mainly India, Eastern Africa, and Brazil. But it is also quite common in the Mediterranean basin, like Southern Europe, Spain. And when we come to Ethiopia, there is a big challenge of co-infection with HIV, and this spot is Gondar, where I am working, and in our catchment area, which is in the northwest part along the Ethio-Sudanese border. It is a very lowland area where there is high transmission of visceral leishmania. So a lot of patients come from that area. They get the infection as this area around is highland area where there is no visceral leishmania, but these highlanders will move to the lowland area to work in the agricultural fields, and then they acquire the infection. And when there is HIV co-infection, because of the suppressed immunity, the disease tends to be expressed. So when the two infections occur together, there is a high chance of having atypical presentation, like I showed you. And it is also a very big diagnostic challenge, especially the serological tests like RK39 or that do not perform well as they perform in HIV negative patients. There is poor parasite clearance, as I showed you in the other case, and high rate of relapse and recurrence, and high mortality. So I will focus more on the treatment challenges than the others. So when you treat HIV and Leishmania co-infection, when Leishmania is treated in HIV patients, quite some proportion get cured with initial treatment, and most require extension of treatment beyond the standard regimen. And quite a number of patients will remain also with persistent parasitemia, and some die. And because of the need for prolonged treatment, repeated treatment, quite a number of patients suffer from adverse effect of the drugs. And there are only limited drugs, very toxic, and adverse effect of the drug itself is one cause of mortality. So even those patients who got cured, be it with a standard initial regimen or after extended treatment, they eventually relapse. So I will show you a couple of slides about the treatment outcome. Sodium stibogluconate is an antimonial drug that is widely available for treatment, and that was a readily available drug in Ethiopia as well. So when the outcome of patients with HIV and without HIV are compared, there was almost a 10-fold increased mortality among HIV co-infected patients. Though the sample size here is smaller, as you see, but I will show you other slides as well where we have quite high rate of mortality and treatment failure with all kind of treatments. So this is a recent experience in my hospital at our research center. Among 57 HIV and visceral Leishmania co-infected patients being on antiretroviral therapy. With the standard 1 month treatment, this was the outcome. There was only 44% of cases who got cured. Otherwise, other patients, there is a high failure rate, higher mortality, and there is a high need of interruption of treatment because of the adverse drug effects. And then most patients require also treatment extension beyond 1 month, and with even prolonged treatment, the final cure rate was 75%. And one observation we noticed is mortality is related to the parasite load that we get at time of diagnosis. And the next drug introduced for the treatment of visceral Leishmania in our region was meltifusine. This is an oral drug. Initially, it was meant for cancer treatment, but it was found also to have effect on Leishmania, and it was used for Leishmania. And the treatment outcome of HIV negative and HIV positive patients with meltifusine again showed that there is less cure rate in HIV positive patients and high failure rate. while the days rate was more or less equal. And then when this outcome was compared with the sodium stibogluconate, an antimonial drug that we often use, there was no much difference in the cure rate, and the treatment failure rate was much lower actually with sodium stibogluconate, but it was at the expense of a lot of days. So it looks like the antimonial drugs are killing the parasite and killing the patients as well. The next medication that was introduced to our region was liposomal amphotericin B. This was supposed to be very safe and effective drug from experiences in the Indian subcontinent. When it was used in Ethiopia, the standard dose being 30 milligram total dose, but it is given in divided doses. The outcome was again very disappointing in HIV co-infected patients. Only 60% cure rate, and the parasitological failure rate was also very high. Almost 1/3 of patients are not clearing their parasite. So it means there is a need for prolonged treatment. And mind you, this is a new drug introduced to the country, so we don't expect a baseline resistance to occur for ambisome. Then we compared also the outcome of patients who have primary visceral leishmania and those patients who are presenting with relapsed disease. And achieving a cure was unimaginable, because there is only close to 1/3 of patients who are getting cured in case of relapsed visceral leishmania disease. And even among primary, the cure rate is not that much satisfactory. And the parasitological failure was tremendously very high among those patients who have relapsed disease. So what was next recommended was to increase the dose of ambisome to 40 milligram per kg total dose than 30 milligram per kg. But this is also very expensive drug and not readily available often to the treatment sites. Then at MSF Holland treatment site, which is also found in a very close place to my center, as a compassionate use, they started to use combination of ambisome and meltiflusin. And with combination treatment, the cure rate was better than what I showed you before. And when it was compared with ambisome monotherapy, it was much higher cure rate, and the parasitological failure has also improved very much. And when the combination was used for patients who have relapse, even though the sample size is small here, we have also achieved better cure rate among relapses with the combination treatment, and the parasitological clearance was also much better than what was possible to be achieved before. So just to say some things about how the immunity and so on work in Leishmania treatment. I'm not an immunologist and I can't say deep things about this, but what happens is during infection there will be an increased humoral response, but this is intracellular organism, so the most important immunity should be the cellular response. And then patients will manifest the disease, you give them treatment, and during treatment the parasite load will be suppressed to a level that can be taken over by the cell-mediated immunity. And then you will achieve cure. But there is no treatment so far that can effectively clear visceral Leishmania parasites from the body once there is infection. So a strong immunity is always very important. What happens in patients with immunosuppression is there will be humoral response whenever there is infection, and then there will be disease manifestation. You treat them, and with treatment, the parastemia will be decreased because of the effect of the drug, but there is no cell-mediated immunity to take over and clear the remaining parasites. So the parasites again start to revive, replicate, and increase, and then patients will be symptomatic again, and then they need retreatment, and with retreatment again there will be decline in the parasitemia, and then if there is no effective cell-mediated immunity again there will be rebound, relapse of disease or recurrence of disease. And with each relapse, the symptoms of the patient start to be low or not that apparent. So there is a need to put high index of suspicion to be able to diagnose these patients when they come with recurrent relapse. Okay. Then what about the experience with antiretroviral therapy? Most of the slides that I showed you are also, those patients were also on antiretroviral therapy, but when antiretroviral therapy effect was assessed on Leishmania patients, what was observed is those patients who have recurrent disease will remain with very low CD4 count. So as a result, they will be prone for relapse, and then they will be prone for other opportunistic infections, and then higher mortality. But those patients who have only primary infection tend to have better CD4 level than those who have relapsing disease. And the relapse rate being on antiretroviral therapy, it is lower. So antiretroviral drugs have effect in preventing relapse, but still being on antiretroviral therapy, 28% of patients relapse, even having CD4 count above 200. Okay. So it means antiretroviral therapy is not enough to guarantee and cure visceral Leishmania or to prevent relapse. And when the risk of relapse was assessed, what was found was it is somehow proportional to the CD4 count. Patients with low CD4 count tend to have higher relapse rates, like the annual relapse almost close to 60%. And with increasing CD4 count, it is the relapse rate declines, but it doesn't come to zero. As I showed you in the earlier slide, up to 28% of patients may relapse, even having CD4 count above 200. So antiretroviral therapy and combination or standard treatment options for visceral Leishmania are not enough to control Leishmania HIV co-infection. So one of the recommendation to control the infection is giving a secondary prophylaxis for those patients who clear their parasite after treatment. So this is an ongoing clinical trial that I am doing at my center at the moment. So recruitment is already finished, but we have some preliminary data. So the pentamidine secondary prophylaxis has a very good effect, but the final result will be available towards the end of this year. So what we can learn from Leishmania to TB? I am afraid I can't say much because Leishmania is a neglected disease and much is not yet done. We have yet to explore a lot, but relatively for TB, there are good strategies in controlling TB HIV activities. But I would like to say some things like there are some similarities between Leishmania and the tuberculosis. When there is infection, some patients will rapidly progress to active disease and some will remain with latent infection and then later on progress to active disease. And then when there is active disease, you treat. This works for Leishmania, also for tuberculosis. And then some patients will have success, some patients will have failure of treatment, and those who succeeded will have relapse, and those who failed need second line treatment. So this is the disease progression, what it looks like for both Leishmania and tuberculosis. Both are also intracellular organisms. And then there is a possibility of drug resistance, especially in tuberculosis. That is a big concern now with rising MDR. So drug resistance is also a concern for visceral Leishmania. So it is not widely spread as tuberculosis now. So when there is HIV, there is a rapid progression from latent infection to active disease. So this is true for TB and also for visceral leishmania. And then there is higher failure rate and higher relapse rate. Okay? So to tackle one target, maybe giving vaccine to prevent infection from the beginning, but there is no effective vaccine. I think for both diseases, there are a lot of clinical, there are preclinical trials going on. And then prevention from latent infection to active disease is another target that can be done, but there is also no as such promising thing available, at least for clinical use at this time. For tuberculosis, INH prophylactic therapy is a good, has shown good effect, but not for visceral leishmania. And then once treatment is successful, the use of secondary prophylaxis is another thing that is recommended, and we are doing clinical trial on that. So the other thing is using heart. So antiretroviral therapy has demonstrated to decrease progression from latent infection to active disease with wide-scale antiretroviral therapy used in the Mediterranean basin. It was found that the visceral leishmania has decreased, like in countries like Spain. Okay? And then failure and relapse can also be decreased with heart, but not 100% promising. So far, the studies are concentrating more on the treatment and then secondary prophylaxis issues and antiretroviral therapy. But to bring about a good difference in the total management, it may be very important to also widen the research areas to an early stage, like latent infection or asymptomatic infection detection. And because if we can target early during that phase, a good difference can come up. Otherwise, visceral leishmania is very challenging. Like once disease starts in HIV patients, then the progression is poor. Okay. If some investments are done on visceral leishmania, getting the parasite is relatively easier than tuberculosis. So what I can suggest is there are a lot of things learned from leishmania, from tuberculosis, but there are a lot of things remaining in leishmania. This is a demonstration of splenic aspiration and then doing microscopy or culture. So when it is relatively easier to get leishmania parasite and then do some fundamental researches to see what is playing the role in the interaction of the two organisms and so on. So one has to check that the patient has no bleeding tendency by doing platelet count, clinical examination, PT and PTT. And then a good dexterity is required to aspirate, because the technique has to be very fast, otherwise patients can bleed from the spleen. This is very risky procedure. Okay. And then I would like to show you another video which demonstrates in a culture media the presence of Leishmania promastigotes that will be grown on NNN media. So you can see here the standard NNN media, and here are the microcultures. So it's possible to grow Leishmania on a microculture or on a standard tube culture, and then getting the parasite so easy will make the subsequent research to be done easier. So I suggest that a lot can be learned from Leishmania that can be used for tuberculosis. So in conclusion, almost all anti-Leishmania drugs nowadays are not so effective for HIV Leishmania co-infection, but relatively ambisome and multifusing combination is safer and has a better effect. So the combination treatment has to be encouraged, and we have already designed a clinical trial to assess this. And antiretroviral therapy improves, but it is not adequate. And secondary prophylaxis clinical trial is already going on. I hope we will have a good result from that. And well, working on the prevention and targeting from the start, from the asymptomatic infection may bring about a change, and that needs more fundamental researches. So I would like to thank my research collaborators and also Harvard University Center for AIDS Research for inviting me to present here. Thank you.
Okay, thank you, Ermias. Questions for Ermias?
So it sounds like you have a high failure rate in treatment, and you have a high failure rate in treatment. I was wondering, how do you define a cure? Do you have very robust clinical or laboratory measures of cure? Are you confident in who's failed or not? What are those measures?
Cure is defined with the negative parasitology from tissue aspirate at the end of treatment. So we have two definitions for cure. One is initial cure, which is at the end of treatment, and then definitive cure at the end of, after 6 months of treatment. So if the patient has cleared parasite from tissue, it is cure.
In that case, I remember the DNDi study. When you do a 6-month splenic biopsy, isn't that quite dangerous? The spleen is already very small at that point.
Yes, there is some difference when we do it from spleen or bone marrow, because the parasite concentration in the two tissue is different, and patients may have regression of spleen at the end of therapy, and then test of cure may be done from bone marrow. But as I said in my presentation, there is no 100% clearance of parasite with drugs. There is always some parasite remaining, which will be contained by the immunity. Okay? By doing tissue aspiration, we are just checking that the visible parasitemia has cleared. So if the patient has regression of spleen, that is also a clinically good sign that he has responded.
You had some cures with the HIV positive individuals, so then I think there's other immune effector mechanisms that are clearing giving you the last bit of the cure there?
Yes, relatively those patients with better CD4 count, better nutritional status, those get cured. But a patient with very low CD4 count and concomitant other infection, the chance of getting cured is very low.
Given all of these other infections that are compromising the HIV or vice versa, can we extrapolate from these numbers to know what is the total percentage, say, of the HIV cases that have comorbidity or mortality due to these extra infections?
Yeah, probably with visceral leishmania it is a bit different, because visceral leishmania is found in some regions. It is not found everywhere, like tuberculosis. So I think this kind of data will be biased with the region.
That sounds like a question that Jerry will answer tomorrow.
For sure.
Any other questions? Okay, well, thank all the speakers again.